Hi everyone. We are going to continue by talking about the hypersensitivity reactions, and we have four of them: the type 1, the type 2, the type 3, and the type 4. Um, the hypersensitivity reactions are just generally um, exaggerated pathological immune response to normal, harmless, exogenous or endogenous antigen, right? And um, we have the four classes like I've mentioned. And what happens in type 1? So type 1 can be responsible for the atopic diseases and the anaphylactic reactions. So what is the mechanism for type 1? I know we are very familiar with this, and I'm going to say first that type 1, type 2, type 3 involves antibodies. It is only type 4 that involves only the T cells, right? Type 1, type 2, type 3 involves the antibodies. So the type 1, which brings about the anaphylactic reactions, the atopic allergic disease, how does it happen? It happens because the antigen that brings about the type 1 hypersensitivity induces the production of IgE. They induce the production of IgE antibodies, and these IgE antibodies bind to or attach to receptors on the mast cells and the basophils, just like we have in this image. So that is the sensitization phase. So you have an antigen getting into somebody. Probably the person is allergic to maybe pollen or dust mites, and the first time the person gets exposed to this antigen, the person induces production of IgE antibodies, and these IgE antibodies get attached to their receptors on the mast cells and the basophils, waiting for the second exposure. And the second exposure brings about the elicitation phase. So when the antigen comes again, the antigen is going to cross-link the IgE receptors, like the IgE like this, and when it binds to them and cross-links them, that triggers degranulation of the mast cells or the basophils. And when the basophils and the mast cells are degranulating, they release some vasoactive amines, including histamine, including prostaglandins, including um, leukotrienes and tryptase. And because of the fact that they are vasoactive, so they cause essentially, majorly, vasodilation of the vessels. And when there's vasodilation of the vessels, you have edema, you have pain, you have erythema, right, of that area. So like cardinal signs of inflammation kind of stuff happens. And there's going to be skin reaction. So you see that area is going to appear red. The person might complain of maybe pruritus, and that area is going to appear swollen as well, right? This antigen, this vasoactive amines too can also trigger some kind of airway reactions, right? They can cause, for example, the histamine is bronchospastic, so it causes contraction of the bronchial muscles, so bringing about wheezing, difficulty in breathing that people with some of these allergic disease experience. So what are the key stuff to remember? The IgE being involved, the cross-linking of the IgE, the release of the vasoactive amines. So the vasoactive amines are going to be responsible for the downstream clinical presentation that is going to happen. So the skin reaction is going to be from them, the bronchial constriction is going to be from them, right? And what are the examples? The anaphylaxis. So somebody gets exposed to a bee sting, food, or a particular drug. So use a drug, takes a particular food, or get exposed to like a wasp or a bee sting, and suddenly the person starts developing some rash, in the body, and the person is having difficulty in breathing due to bronchospasm, wheezing, and the person is having subcutaneous tissue edema, right, due to the vasodilation and extravasation of fluid into the subcutaneous tissue. So the person can also have facial swelling, can have neck swelling, can have hypotension, right? So that is characteristic for anaphylaxis. It is a type 1 hypersensitivity. Asthma is another atopic disease that can happen from type 1 hypersensitivity. So here they will be having more of their wheezing, their difficulty in breathing, the shortness of breath, because of exposure to some particular antigen that induce the IgE cross-linking. The urticaria rash is just like the typical wheal and the flare that you experience following exposure to this allergic stimulus, which brings about um, vasodilation of the vessels, you know, and particularly within the dermal capillaries, leading to formation of transient, plaques and papules, which has the urticaria rash. So that is that about the type 1. For the type 2, here we are not looking at IgE anymore. We are looking at IgM and IgG. So there are some disease conditions or some hypersensitivity conditions that are shared with production of like autoimmune antibodies, like autoantibodies rather. So autoantibodies, antibodies that have the tendency to destroy self-antigens, right? And what are these antibodies? We are particular about them. It is not IgE, but it is IgM and IgG. IgM and IgG. So these auto antibodies have been produced for whatever reason, and they start binding to the self antigen, recognizing them as enemy cells. And the effect of this IgM and IgG on these antigens um, affect the presentation, affect the disease entity or the pathology as a whole. For example, this IgG or the IgM can bind to the cellular antigen, and it can induce the formation of the activation of the complement and activation of the phagocytes, right? Like the macrophages, which will end up triggering inflammation. They can stop there. Some can induce the complement, and the complement mediated lysis can happen. Destruction can happen, and you have destruction of that cell. Some can just bind. Some antibodies can just bind to the to the antigen, and they will just um, influence the signaling pathway within that cell. They can either activate the signaling pathway, or um, they deactivate or they reduce the signaling pathway. Excuse me for a minute. Put on my phone. So um, that is that. So some will activate the complement, the phagocyte that leads to inflammation. Some will activate the complement that causes lysis of the cell, which is destruction. Some will affect the signaling, right, of the cell, overactivating the cell, or even under activating the cell. So don't forget the IgM and the IgG are being produced, you know, and they are the ones that will bind to the antigens within the cell and affect the cellular responses. So some can lead to formation of membrane attack complex, that will lead to destruction of the cell. So looking at the category, so if we want to talk about the ones that destroy, you know, if we categorize it like that, we are going to have more disease to remember, right? So based on the one that cause formation of the membrane attack complex of the complement and eventual cell destruction, you have stuff like autoimmune hemolytic anemia, right? You have just remember the hemolytic anemias, autoimmune hemolytic anemia, hemolytic anemia of the newborn, um, acute hemolytic transfusion reaction. It is an example of a type 2 cytotoxic reaction because you have antibodies formed against the red blood cell that destroys the red blood cells. So erythroblastosis fetalis is the hemolytic disease of the newborn, the autoimmune hemolytic anemia, both the warm and the cold, and the ones that are shared with inflammation. So they activate the complement, they activate the macrophage, which trigger inflammatory responses. You have disease like Goodpasture syndrome. Because in Goodpasture, you have antibodies against the alpha 3 chain of the type 4 collagen, right, within the basement membrane of the lungs, the basement membrane of the kidneys, right, triggering inflammation. So which brings about the nephritis that is characteristic of Goodpasture syndrome. So same with rheumatic fever, the carditis that is characterized by rheumatic fever. It's due to inflammation of the heart muscle, right? That's why they have some of that presentation. It's due to inflammation. Then the last one is the one that affects the signaling, the one that overactivates, like in Graves' disease now. It's due to autoantibodies, the anti-TSH, antibody that stimulate the TSH receptor, leading to overdrive of the thyroid function. That is overactivation. Another example is when you have so I've talked about the Graves' disease. I talk about the bullous lesions, the bullous pemphigoid, the pemphigoid vulgaris. All those ones you are under activating the activity of the desmoglein 1 and 3. So when the desmoglein 1 and 3 is not functioning anymore, you have the formation of this bullous lesion because you can easily separate the intraepidermal cells, right? So that's that about the the type 2. Then moving on to the type 3. These ones are the ones that are shared with deposition of immune complexes. So unlike type 2, which is the only antibody that is mediating the action, in type 3, the antibody is binding to antigens within the circulation and they now come together to deposit in tissues. When they deposit in tissues, they can activate complement and they can activate neutrophils. The neutrophils will now come to now finalize the problem by releasing lysosomal enzymes that will now start destroying, the tissue function, right? So that's the way it works. You have antibody and antigen mixing in the blood, now depositing in tissues. That's the way it works. Activating complement, right? And also the neutrophils at the end of the day. So it mediates so many glomerulonephritis and vasculitis. So think about glomerulonephritis, think about vasculitis. Talking about vasculitis, think about stuff like polyarthritis nodosa. It is a type 3 hypersensitivity reaction, right? Some say that it's due to hepatitis B. So hepatitis B is the antigen, and you have antibody forms against this hepatitis antigen. They come together and they start depositing within the vessels, of the kidneys and the like, causing polyarthritis nodosa manifestation. They can deposit within the neurons, the GIT, right? The vessels along these organs, causing different pathology. And also for glomerulonephritis, like post-streptococcal glomerulonephritis is a very, very good example. You have the antigen, which is your streptococcal antigen, and also antibody against that antigen. They deposit within the tissues like the renal vessels, and they start causing damage to the renal parenchyma. So, that is the way it is. Polyarthritis nodosa, immune complex glomerulonephritis, which is also known as the post-streptococcal SLE, right? Rheumatoid arthritis, some autoimmune disease like that. SLE, rheumatoid arthritis, all of them they are shared with type 3 deposit. Then type 4 is the one that does not involve antibody, right? So these occur when you have exposure to maybe an antigen initially, and that antigen has stimulated the differentiation of the T cells. So you already have memory T cells that can remember that antigen. By the time the antigen is coming again, you already have T cells, that are stable, that can recognize it and trigger a massive reaction. So that's what you have in your delay type hypersensitivity reaction, which is your type 4, because it takes some time for you to, sensitize the T cells, form the memory cells, and exert the inflammatory response to the antigen. So that's why it's usually delayed. It's delayed. It doesn't happen quickly like in the anaphylactic or the atopic disease, which is within minutes to hours. But your delayed takes longer time, right? So and it's cell mediated because it doesn't have involve the antibody. You don't call it any humoral stuff. It is strictly cell mediated, and you cannot transfer it by serum. So if it's antibody issues now, you can transfer it by serum. But if it's just the T cells, you cannot transfer by serum, right? Because you need to, get the T cells into that particular patient, and there has to be sensitization of those T cells. So it involves like processes. But if it's an antibody mediated problem now, let's say like in type 2, like let's say like in Graves, what you just need to transmit to that recipient is just the antibody, which is the TSH antibody. Once the TSH antibody gets into that patient, it will go and stimulate the TSH receptor of that patient, and it will continue the process. So you can say that it is transmissible by serum or across the placenta. But in your type 4, you can't do that, because even if your T cells is there, there's nothing to trigger it to, activate, to release cytokines to cause macrophage activation. You still need to trigger it. So you cannot transfer your type 4 by serum, right? So you don't need to even try to do a lot of concept analysis. Just know that type 4 is the only one, which is the only different one that does not involve antibody, and you cannot transmit it by serum, right? An example of the type 4 is your skin test, your tuberculosis skin test, your candida skin test, the transplant rejection. So I forgot to mention, they can put it in your exam, the hyper acute rejection. So the hyperacute rejection is an example of inflammation under type 2, right? So you already have preformed antibodies within um the recipient. So by the time the donor, donate the graft containing the antigen will just react to the antibodies within the donor, and it will lead to inflammation. So that's why you tend to have like a form of like um, inflammatory response within the vessels of that graft that you're accepting, and it leads to thrombosis and ischemia at the end of the day. And you have a rejection within like 24 hours after you have done your transplant, and the immediate thing you have to do is to remove it. That's hyperacute. It is due to a type 2 hypersensitivity because you have preformed antibodies already in the recipient, right? But the other ones, which is acute, chronic, and the graft versus host, they are type 4 mediated. They involve the activity of the T cells, CD4 cells, CD8 cells, they are both involved, right? And they have to release lymphokines that affect that stimulate the macrophage that will now cause the destruction or the the reaction at the end of the day. So contact dermatitis, which we are going to talk about very well, the acute, the chronic, and the graft versus host rejection, the tuberculosis skin test, your candida skin test, they are all type 4. They are all type 4. So um moving on to each of those pathology one by one. So atopic dermatitis is first, and we cannot go for exam and we don't know atopic dermatitis. It is very dangerous. So atopic dermatitis is strict. It's just more like a chronic inflammatory dermatitis, that affects infant that starts at infancy and passes into adulthood. How does it happen? It's just due to epithelial barrier dysfunction, due to mutation in a gene that we call the filaggrin. So there is mutation of filaggrin, and this filaggrin just helps to protect the integrity of the epidermis, so that it doesn't allow for unnecessary water loss and dryness of the skin. So once there's mutation in filaggrin, you have a compromise of the epithelial barrier, and there's easy movement of water from the skin. So water can leave, moisture can leave, and the skin will appear dry. And when the epithelial barrier is compromised, you can easily have entry of irritants, allergen, microbes into the skin, which can trigger inflammation, right? Just like we have here, they can easily trigger inflammation, So the inflammatory response, the dryness, the skin dryness or the xerosis, right? The skin dryness, the skin dryness, the dryness, you know, and the xerosis, with the inflammation can bring about pruritus. So atopic dermatitis is very, very puritic. And if something is puritic, that means it will keep scratching, scratching, and scratching, leading to hypertrophy of that skin, hyperpigmentation of that skin, and lichenification at the end of the day. So, one thing I must mention with respect to the nature of the lesion that we are looking for in atopic dermatitis is what? Papulovesicular lesions. Please don't forget that. Papulovesicular lesions. That is what we are looking out for. Papulovesicular lesions. So we are looking for papulovesicular lesions. Papules and vesicles. That is what we are looking for in the question state. Papules and vesicles. Papules and vesicles. Papules and vesicles. So we have some short note here that long-term use of immunomodulating medications like TNF alpha inhibitors can increase the risk of developing lymphoma. Not only in lymphoma, they can activate TB, they can activate hepatitis, they can cause lymphoma, they can activate latent malignancies. The reason being that the immune cells are very, very much important in immunosurveillance. So they watch out for, potential error sites like cancer sites, like cancer. So and eradicate all those cells, the cancerous cells, like your CD8 4 cells, your CD8 4, your CD8 cells rather, I said CD8 4, your CD8 cells, that is what they normally do. Immunosurveillance, watching out for potential cells that have like showing signs of malignant transformation, and they eradicate them. But if you have your TNF inhibitors, you are suppressing, the activity of those CD8 cells, because they require the release of TNF lymphokines to work. So if you have suppressed the activity of TNF, that means that there's no way your CD8 cells can work. So there's going to be like a form of immunodeficiency in a way, so leading to a high risk of developing cancers like lymphomas, right? So that is that. And going back to the atopic dermatitis, how will they present? So first of all, you have to obtain a family history. You know, that is not the first thing, but we are just saying what you are going to look out for in the question stem. So because atopic dermatitis is one of those allergic disease that's actually with type 1 hypersensitivity. So they might tell you that the person has a family or a personal history of asthma, allergic dermatitis, which is eczema we are talking about. That is the one we are even trying to discuss, or allergic rhinitis, right? Or allergic conjunctivitis, right? Or even allergy to some food. That once the person starts eating up some food, start having diarrhea, having some rash, appear in the body, that's going to be food allergy. So watch out for the allergic triad or the atopic triad. The asthma, allergic dermatitis, allergic rhinitis, allergic conjunctivitis, food allergy, they go together. They go together. So I'm just trying to follow the way it's arranged in our book so that I don't miss out anything, right? Patients with allergic dermatitis are at risk of some secondary infections. So I have 4 of them, right? And I have it here. So the first disease is impetigo. Let me show us so that it will be clearer. So the first disease is impetigo. So all those lesions, the papulovesicular lesions of the allergic dermatitis can get secondarily infected, right, with Staph aureus or Streptococcus pyogenes, causing impetigo. And if it's going to be due to Staph aureus, it's going to form bullous impetigo. If it's going to be Strep pyogene, it's going to be what? Non-bullous impetigo. And what are we going to see? We'll get the history that the person has a atopic dermatitis. They will have painted it. And the next thing they will tell us that the person started developing some rash later on, which are identified as papules or pustules with honey crusted golden colored adherent coating. You see, that is what we need to look out for. That honey crusting, over that lesion. We know this is likely to be impetigo. Once you see honey crusting, golden honey crusting, from papules or pustules, impetigo. If it's bullous, as bullous impetigo, Staph aureus. If it's non-bullous, Streptococcus pyogenes. If the presentation is localized, just apply topical mupirocin. Apply topical mupirocin. I have it down here. Apply topical mupirocin. If it's widespread, use systemic drug, which is what? Oral cephalexin. It works against these organisms, right? The second infection that can happen in people with atopic dermatitis is what we call eczema. So eczema is also known as atopic dermatitis, eczema epithecal. So that means that this patient is going to be having herpes simplex infection. And how is it going to present? They are going to tell you that the person has some lesion that occurred later, which is what? Evolution into painful vesicles, because of course we know herpes infections are usually characterized by vesicles, right? So we have vesicular lesions with erythematous space evolving into punched out erosions and hemorrhagic crust. You see, this is just story. What we are saying is that we are going to be seeing vesicles, fluid-like papules, fluid-containing papules, that they are going to burst, leading to erosions. The bursting is just affecting the superficial layer of the skin, which is the epidermis. And the content, which is blood, serum, is going to leak out and it's going to crust over the skin surface. So once you get the history of crust, but this crust is not golden yellow, it's not honey colored, right? It is hemorrhagic crust with vesicles. Think about herpes, eczematous epithecal. And in addition to all these lesions, you are going to get history of fever, headache, malaise, and of course, lymphadenopathy. So, lymphadenopathy, fever, headache, malaise with somebody that presents with vesicles that are very painful, that now rupture, forming erosion, and the content, which is the blood, now crossed over the surface. Eczema epithecal. The next is the molluscum contagiosum. So, molluscum contagiosum can get entry, you know, and the individual will develop skin-colored lesions with central umbilication, right? So let us look for uh, some of those lesions. Uh, let's see, um, eczematous epithecum. Yeah. So we have it here. You can see. You can see the initial vesicles, right? These are the vesicular lesions, and we can see the crusting, the hemorrhagic crusting here. So this is what they are going to tell us after talking about initial history of an atopic dermatitis. He said later the person has started developing this lesion. You know that this is a secondary complication. Secondary complication. Very, very important stuff. Now, the next is what? Tinea corporis. Tinea corporis. And this is going to be described as the individual now having pruritic, circular, or annular plaque with central clearing, having a raised scaly border. So pruritic annular patch with central clearing and a what? Raised scaly border. Very important stuff. Once you see pruritic annular lesions with central clearing and they have raised scaly border, think about tinea corporis. Think about tinea corporis as a complication of the atopic dermatitis. You know, we have been talking about this and we have not even described the lesion of atopic dermatitis itself. We're still going to get to it. So all these things usually happen because of the constant waxing, waning cycles of the scratching, the excoriation, you know, breaking the skin at the end of the day. So the trigger for the lesions usually is actually climate change, especially low humidity, like maybe you eat some particular food, or skin irritants, especially people that use all these ash creams, ash creams, hard soap, hard soap, use it to wash your skin, and you have history of you have a tendency to develop allergic dermatitis, it just comes straight away, or you get exposed to some certain allergens, they can trigger the development of this allergic dermatitis. So, what are the manifestations? So, this is the most important part, and the manifestation depends on the age. The manifestation depends on the what? The age. So, if it's an infant, young person, it's usually confined to the face and the extensor surface of the body. The face and the extensor surface of the body. Please don't forget that. What is the lesion that we have talked about? The what? The papulovesicular lesion. So you are going to get erythematous, reddish, papules, and vesicles, right? Sometimes they will describe them as being weeping. Just see them, tiny, tiny dots. They can have some discharge from it too. So they are being called weeping lesions, but they are going to be pruritic because they are going to be scratching it. Pruritic, erythematous, papules, and vesicles, right? Don't forget that. In the face of a young child, think about atopic dermatitis. In the face, particularly within the cheek, the scalp, or the extensor surface of the extremity, like the backside of the hand or the forearm. The diaper area is not affected. This is not seborrheic dermatitis. The diaper area is not affected. So you see a child having erythematous, pruritic, papulovesicular lesions in the face and the extremities, the external surface of the extremities. Think about atopic dermatitis for an infant. If it's a child, if it's now more than 2 years, children and adults, the distribution changes, right? So it now starts changing to the flexural area. So don't forget, these lesions are usually dry because it's eczematous lesion. They are dry because we have said what happens. Epithelial barrier being destroyed, acceleration of fluid. Fluid is just moisture is just leaving. So they are dry, they are scaly, they are puritic. Papulovesicles, you can see it again. Excoriated papules and vesicles, right? And sometimes you can have plaque, but have your papules and vesicles with you first. Dry, scaly, puritic, excoriated. Papules and vesicles. Now in the flexure areas, in a child, the flexure areas, like the anterior part of the forearm and the neck, right? Think about atopic dermatitis. The same thing with adults too. The same thing. Dry, scaly, puritic, excoriated vesicles and papules in the flexural areas, right? The hand, the wrist, the neck, right? With lichenification, because they will have scratches. It will have become thickened. The skin lines will have disappeared. That area is going to look hyperpigmented. That's lichenification due to the constant scratching from the excoriation, right? So that is that about atopic dermatitis. And um, how do you make a diagnosis? Most of the dermatologic disorders, they are clinical diagnosis. You have to have that at the back of your mind. Most of them, they are clinical diagnosis. But sometimes you can have some degree of overlap. So you might want to exclude. So you might exclude your contact dermatitis by the history and the anatomic distribution. So most of the time, contact dermatitis is not widespread. It's just confined to a certain area that is getting exposed to the irritant or the allergic agent, right? So and from the history, you will not have family history of maybe atopy like allergic conjunctivitis, rhinitis, and the distribution too can vary. Most of the time, contact dermatitis occurs within the heart, especially with irritant dermatitis. We are going to get there and we are going to talk more about it. Potassium hydroxide prep can help you distinguish it from tinea. Why? Why are we saying tinea? Because atopic dermatitis can be dry, can be scaly, can be puritic, and these are also common findings in tinea infection. They can be dry, they can be scaly, they can be puritic. So sometimes, if you are not clear and you are not sure, you might need to do a potassium hydroxide prep to differentiate the chronic eczema from tinea infection, right? Because this is an allergic condition, you can have presence of peripheral eosinophilia and elevated IgE. This means nothing because it adds no diagnostic value. Even if your IgE is 1 billion, it means nothing. So we have the erythema toxicorum neonatorum. I think Dr. Festus will still talk about some of these pediatric um, dermatosis in our pediatric section. I don't know, but I'll still be looking for ways to chip in some of them because there are about 5 or so. So ETN, like I normally call it, ETN, that's erythema toxicum neonatorum, usually occurs within 1 to 3 days after delivery. And what you are looking out for is just papules and pustules. That's what I look out for. They usually have erythematous, papules, and pustules within the trunk and the proximal extremities. So a child that is born and the child is having papules and pustules 1 to 3 days after delivery, which is distributed within the trunk and the proximal extremities. I think about erythema toxicum neonatorum. Erythema toxicum neonatorum. If you biopsy some of these lesions, you can see elevated eosinophils and pustules there. But one thing about it is that you don't need to do anything. It is a benign eruption and it resolves within 1 or 2 weeks with no treatment. So erythema ETN starts 1 to 3 days after birth and resolves 1 to 2 weeks after birth. And what are you looking out for? What are you looking out for? Pustules and papules, erythematous pustules and papules within the trunk and the proximal extremities. Within the trunk and the proximal extremities. Very easy stuff. Very, very easy stuff. So looking at the treatment of atopy generally. So looking at the treatment, the primary goal of therapy is just to break the itch scratch cycle. That's what you want to do because it is a constant itching you know, from the inflammation, just like I mentioned, from the dry skin, that brings about damage to the skin and allowing for entry of um for of other just um before I continue, I'm just going to show us a picture of the erythema toxicum unatorum so we can see these lesions here. Um we can see like the pustules not very clear, but um we can see the papules and some pustular lesions here and there, in the infant. You can see here the trunk, the side of the face, the proximal extremity. So it's usually very common within the proximal extremities and the trunk. So the pulse field lesions, the pustules, not very clear, but we should watch out for those lesions, the pustules, the papules within the trunk and the proximal extremities, and these babies are delivered within, like, after they are delivered 1 or 2 3 days after they are delivered, you start seeing the lesion. So that's very important. And we go back to the treatment of atopic dermatitis. So just like I was saying the other time, um, the main goal of therapy is to break the itch scratch cycle. So because the major cause of the itching is the dry skin, which is the xerosis, as well as the inflammation. So both of them, they work in concert to bring about the pruritus, which is a major cause of the itchiness. And the more the individual itches that area, the more the denudation of the skin barrier, and the more you have the chance of complications, because the virus, the bacteria will gain entry and it will cause secondary infection. So you want to provide some symptomatic relief to reduce the itchiness, right? So, and you can do that by giving your H1 blockers first, right? You give your H1 blockers, which is your first generation antihistamine, like hydroxyzine, hydroxyzine. So you give your hydroxyzine usually at night because most of them have sedative effect. Don't forget that. So you use it at night to relieve the pruritus. You also have to apply Hemulant, right? Hemulant. Um, that will help you also with the symptomatic relief, because it's going to increase like the moisture content of the skin and help to prevent future episodes. But if you want to do your definitive treatment, the first line for atopic dermatitis is what? Topical corticosteroid. Very, very important. So for the flares, you have to give topical corticosteroid. That's the first line, right? But you might want to minimize the use of this steroid, particularly in the face, because of the risk of atrophy, telangiectasial, and rebound flares. So once you use your corticosteroid for a long time, there's a high chance of developing these lesions in rebound, and there's a high chance of skin atrophy and telangiectasias. So you have to be careful with the duration of use of the topical corticosteroid. But most of the time, if they put it in the question, the first line for treatment of atopic dermatitis, we are going to pick topical corticosteroid application, right? Um, Sometimes you might need to use steroid sparing agents, particularly if you want to use it for a long time, for individuals in moderate to severe eczema, and they are more than 2 years. You can use topical calcineurin inhibitors like our pimecrolimus, our tacrolimus. So they are calcineurin inhibitors. They are steroid sparing. So they allow you to achieve what you are going to achieve with the use of steroids without using steroids. So they are very, very good for moderate to severe atopic dermatitis in individuals that are more than 2 years of age. Or if you have been using your steroid for a long time, it's not working, you can try your topical calcineurin inhibitors. So to prevent future occurrence, you must make sure that you are using your Hemulant. You avoid the triggers, right? Hard soaps, hard or harsh soaps. Avoid that, and limiting hot showers after resolution of the acute flares, because hot showers can also trigger um, future episodes. So you want to limit hot showers. You want to avoid irritants like using the hard soaps. You know, um, prevent exposure to the allergens, right? So those are the major stuff. But if your first line doesn't work, your second line doesn't work, you might need to do some systemic treatment by, getting exposed to phototherapy or using immunomodulators like dupilumab. So your dupilumab inhibits interleukin 4 and interleukin 13 and prevents release of IgE, right? Which is one of those cardinal component of the inflammatory response. So because this is atopic dermatitis we are talking about, so IgE plays a very important role. So just to summarize, to provide your symptomatic relief, you give your antihistamines to reduce the pruritus, your emollients, right? But the first line for treatment is your topical corticosteroids. But you cannot use it for a long time because of the risk of atrophy, telangiectasia, rebound flares, and other, symptoms or complication of steroid that we know. We already know some of those things. So if you are going to be using it for a long time, you can switch to your topical calcineurin inhibitors like your tacrolimus, pimecrolimus, particularly in people with moderate to severe eczema and the patient is more than 2 years of age, right? So avoid the triggers, getting exposed to high temperature, harsh soaps to prevent, the future episodes. And if the calcineurin is not working or corticosteroid is not working, you can consider phototherapy or give systemic immunomodulators like dupilumab. That is that about atopic dermatitis. The most important thing is to be able to recognize the lesions, right? The distribution of the lesions depending on the age group. We already know that the comorbidities that can happen with it, as well as the secondary infection, so that can occur in individuals with atopic dermatitis. Um, Contact dermatitis is another one. So more like there's an omission here because contact dermatitis is categorized into two forms. We have the irritant contact dermatitis and the allergic contact dermatitis. So here in our first stage, most of the time they talk about the allergic only, but the two of them are important. The irritant contact dermatitis and allergic contact dermatitis. So what we are just saying here is that we are seeing lesions, right, in an area that is exposed to irritants or an allergic stimulus only, right? So um, just to make sure that I'm not talking blindly, I have to show us what I have in my notes, which is just a guide to explain, right? Um, Contact dermatitis itself can be categorized into two forms, just like I've said, the allergic contact dermatitis and the irritant contact dermatitis. The irritant contact dermatitis can be categorized into the acute form and the chronic form. So you can have acute irritant contact dermatitis and chronic irritant contact dermatitis. Most of the time, the allergic contact dermatitis occurs in acute setting. So it doesn't take too long from the exposure to the onset of the symptoms. So it's usually acute. And the allergic contact dermatitis is due to a type 4 hypersensitivity reaction to exposure to some allergic agents. And what are these common allergic agents? These are stuff we need to know. So what we have here in this page I'm showing us is allergic contact dermatitis. So it is a type 4 hypersensitivity reaction that occurs from contact with an allergen, right? And just like I've said earlier, most of this allergic process occurs in two basic phases. The first one is a sensitization phase, and the second is a elicitation phase. So the individual is going to get exposed to the allergen first, and the individual is going to be sensitized because when the individual is exposed to the allergen, you are going to have differentiation of the antigen presenting cells are going to capture that allergen and are going to present it to the naive T cells. And the naive T cells will differentiate into the right proper T cells that can respond to the antigen and they will be kept. So that is the sensitization. The elicitation is now when you have now re-exposure to that allergen. So your T cells are already in situ, they're already active. By the time the antigen, the allergen comes again, your T cells will respond to it. They will secrete the cytokines that will activate the macrophage, which will cause the immune response and the development of the lesions. So that is the type 4 hypersensitivity. You can see that it basically involves the T cells, the cellular mediated immunity majorly, right? So that is the allergic contact dermatitis. And the potential allergen that we should look out for in the question is stuff like the poison ivy. So poison ivy, poison oak, um, poison oak, poison ivy, poison oak, spell that, poison sumac. All of them, they are plants. They are plants, and they contain a resin that we call urushiol. So they contain a resin that we call urushiol, and this urushiol is a potential allergen, that can stimulate, a type 4 hypersensitivity reaction. So they can just print it in this question stem that the individual get just finished maybe a walk, in a park, or went for gardening, or just had a trip somewhere within the mountains that we have trees and the likes. And, after some hours, the individual started, developing some rash within a particular part of the body, maybe the legs or the arm, or the hands. Any area that you feel that, has a high chance of encountering, the tree or the plant, right? Usually the legs and the upper extremities generally. So the plant includes, you know, the poison ivy plant, the poison oak, and the poison sumac, right? Then individuals can also get exposed to the allergen from nickel. People that use nickel containing jewelry, right? People that use topical neomycin. So I think about the hands first, the neomycin, the nickel, and the poisons, right, from the plant, the poison ivy, the poison oak, the poison sumac that contain urushiol, right? So people that also use some sprays, some deodorants, perfumes, can also have this type 4 hypersensitivity. And it will be very common. It will first develop in the area where you have applied that allergen, maybe the neck, in the jewelry, where you apply the topical neomycin, where you spray the deodorant and the perfumes, right? This is very common in adults because adults are the ones that, wear jewelry, use deodorants, apply medications to their body. So that's why contact dermatitis is very common in adult population. So that's the first stuff to take note of for the allergic contact dermatitis. And because I've said it that the symptoms are usually acute, so you typically have, lesions that it's very similar to what you have in allergic in atopic dermatitis too. So, and which is what the I know you want to tell me the papulovesicular lesion. So very important stuff. The papulovesicular lesion. You are going to see them here too. Although in addition to that, you can see plaques. And when it's very severe, you see bullae. That's where it works here. You see the plaques, you see puritic red indurated papules or plaques with vesicles and bullae in severe cases, right? That's what you usually have. you know so rubber latex is another one. Rubber latex can be another allergen. Leather dyes, people that use leather dye, can also get exposed to this type of hypersensitivity stuff. So they usually present with pruritus. It's very pruritic, and they have the typical enzymatous rash, because this rash are, they are erythematous, they are swollen erythematous, and they, appear as papules and vesicles, right? And the distribution, is confined to the area of contact, right? The distribution of that rash is confined to the area of contact. So that's what it means by this statement, that the distribution of the rash often mimics the contact event. So you typically see the rash where you have applied the makeup, where you have wore the clothes, you apply the perfume, the nickel jewelry, and the plants. You can see this is very straightforward. It is not usually generalized, usually localized to the area of contact, where the body has being in contact with the allergen, right? And they usually have this angular or linear, pattern, which we are going to see. So just look at this. So definitely, this upper part of this, shoe contains a form of, allergen, that is irritating the skin and inducing, that is, no, not irritating now. If we are saying allergic contact dermatitis, it means the allergen here is the one that is inducing the type 4 hypersensitivity, not irritation. So if it's irritant contact dermatitis, it could now be from the physical irritation from the shoe, which we are going to talk about too. So you see the lesions appearing as linear and angular rash, right? And they can spread all over the body by the transfer of the allergen, maybe from the hands or the limbs, or by traveling and circulation of the T lymphocytes, the sensitized T lymphocytes. So these are the frequently implicated allergens that you must never forget: the poison Harvey, the poison Suma, the poison Hook, right? The nickel jewelry, right? Over the counter antibiotics, cosmetics, and latex. Cosmetics, latex, antibiotics like neomycin, right? Topical neomycin is very commonly implicated. So um, that is that about allergic contact dermatitis. Don't forget about the implicating allergen. Don't forget about the distribution of the rash. It is angular, linear, confined to the area of the contact. Sometimes it can disseminate, it can move outwards. Maybe when you have circulation of the T lymphocytes, or you have, inoculation to other sites by the hands, depending on the allergen. And the typical lesions appear papullo-vesicular. So you see the papules, you see the vesicles, you see the plaques sometimes, and if it's very severe, you see the bullae, right? That is that about allergic contact dermatitis. So for the situation of irritant contact dermatitis, this is quite different from allergy because this is not mediated by type 4 hypersensitivity. So the irritant is usually due to irritation of the skin by chemical agents or physical agents. So you have a physical or chemical trauma to the skin, damaging the keratinocytes. And when the keratinocytes are damaged, there's inflammatory response that brings about the rash. So if we are suspecting rather irritant contact dermatitis in the question stem, that is not the time to pick type 4 hypersensitivity. We'll be looking out for an option suggestive of physical or chemical trauma to the skin keratinocytes with a subsequent inflammatory response. The lesions are quite similar. You are going to see the red, pruritic, indurated, papules and plaque, vesicles and the bullae, just like we have in allergic. Similar lesions. It's just the the trigger, that is going to separate them, right? So for irritants, it's going to be chemical or physical agent. So for the chemicals, we have stuff like soap and detergent. So if they tell us that somebody is using soap and detergent to the hands and develops the rash, you are not going to pick allergic. It's going to be irritant. Soap and detergent, alkali and bases, alkali and acid rather, or acid and bases, um, um, soap and detergent. You know, those are the common chemicals. Then for the physical one, it could be to due to exposure to some compounds like what's it called, metals. It could be to exposure to, I think I have them here, metals, you know, glass fibers, dust, wood, all those things. So I have them here. I think I have them here. So the physical irritants like metals, like wood, like fiberglass. Then for the chemical, you have stuff like your detergent, the soaps, the acid, the bases. So all of these can damage the keratinocyte, lead to an inflammation with the subsequent lesions, and you can make your diagnosis. So that's the way it works. But the only difference is you can have a acute episode for irritants as well as a chronic episode. So what you see in the chronic episode is that the individual, just like I have here, the individual is going to be presenting with lichenification because it's very pruritic. So the constant scratching, will lead to the lichenification of that skin, in which you start seeing xerosis, dryness, scaling, you know, hyperkeratosis, hyperpigmentation, and fissures of that area. So the skin markings here, they are going to be blur, they will be totally absent, right? And you are going to be seeing fissures. You can see um, scaling, and of course, that area is going to be thick and dry. So that's that. I think I should have a picture of irritant contact dermatitis, so you can see. So this is just the example of the fissures. So you can see the break in the skin, kind of. These are the fissures. Um, and one thing I must also mention about irritant contact is that most of the time you find it in the hands. Most of the time it is in the hands. Application of soap and detergent to the hands, application of strong acids and alkali to the hands. Most of the time it is the hands that get exposed. Um, so you know this is the like education. You can see that this skin is looking thick, looking dry, it's looking scaly. So this is a lichenified skin. It's suggestive of irritant contact dermatitis that is chronic. That is chronic. So we should not forget about that. So what do you do? What do you do? To make diagnosis, number one, it's clinical. The history and the examination findings are sufficient, but you might need to exclude atopic dermatitis because they are quite similar, right? You need to exclude atopic dermatitis. You look at the pattern, right? Because you expect atopic dermatitis to be occurring at the flexural areas, the the cubital, antecubital fossa, the wrist, the neck, particularly in adults. Then in children, you see it in the face, the cheek, the extensor surface. After you have excluded atopic dermatitis, you have obtained history of the allergen, allergic disease, atopic disease like atopic conjunctivitis, rhinitis, asthma, and they're absent. Okay, then you know that what you are dealing with is likely to be contact dermatitis. Then you can do your patch testing. But one thing about the patch testing is that you are just applying like a patch that contains the common allergen that can trigger this contact dermatitis. So they just apply the patch to the skin, and after like 48 hours, you check for the induration or the evidence of the inflammation, maybe bumpy lesions or redness or the likes, so that you can pinpoint the specific allergic agent that is causing that contact dermatitis. Um, the patch testing is usually done after you have treated the acute flare, right? After you have treated that active phase eruption, right? But if you treat the individual now, you have to wait for like, let's say, like 3 to 5 days or like a week, before you do your patch test. Why? Because part of what you use to treat includes topical steroids, right? Topical steroid, and we know that topical steroids, they tend to blunt immune response, and the patch testing involve immune response because you are kind of trying to generate a minimal or a small contact dermatitis within an area of the skin so that you can identify the antigen involved, right? You apply the patch to the skin and you watch out for the reaction. So each of the patch is labeled, so you know the antigen in each of the patch. So by the time you remove it, you now check for the one that is reacting. So if it's the patch that contains neomycin that is reacting, you know that okay, this is likely to be neomycin induced allergic contact dermatitis. So you tell the person to keep off from neomycin, right? So that's the way the patch testing work. But steroids, and that reaction involves inflammation, but steroids will blunt the inflammatory response. So you might have a false negative result. So you want to ensure that you have spaced the test to after the person have used steroid for a long time. Maybe what I mean is if um let's say that person uses the steroid like a week ago, then you can do your patch test. But if the person used the steroid like a day or 2 days ago, the steroids are still in the circulation, so they can blunt that inflammatory drive. So you don't do your patch test then. You have to space it to like 3 days afterwards. Then you do your patch test to determine the implicating antigen. So your topical steroid can affect your patch testing results. The calcineurin inhibitors too can affect the path testing results. It's only antihistamine that cannot affect. So because some of them might be placed on antihistamine for the varieties. So antihistamine they don't blunt the inflammatory response like steroids or calcineurin inhibitors, because the type 4 hypersensitivity that mediates um, the allergic contact dermatitis is not histamine mediated. So how do you treat individual with contact dermatitis? You just avoid the allergen. Number one, stuff. If it's the irritant, avoid the irritant. If it's allergic, avoid the allergen. Then you can apply topical corticosteroids. But if it's severe, it's not responding to topical corticosteroids, so it's just like widespread, you can give a systemic corticosteroid, in that situation. Moving on to seborrheic dermatitis. So the seborrheic dermatitis is like a very common chronic inflammatory skin disease that is caused by reaction to a particular fungi, which is called Malassezia fortior. Malassezia fortior. Malassezia fortior is implicated in so many dermatology conditions. Seborrheic dermatitis is one. We'll talk about the pityriasis versicolor too later. So, but this guy is a normal colonizer of the skin because it is one harmless yeast that you find in sebum, which is the oily secretion of the skin that keeps the skin supple and the hair follicles. So that's where you find it. Anywhere that is rich in sebum, you find your Malassezia fortior colonizing that area. So areas that are abundant in sebaceous gland like the eyebrows, the nasolabial folds, the posterior hairs, right? Those are the areas where you see seborrheic dermatitis. But seborrheic dermatitis can occur usually very common in two peak ages. Number one is the first year, within the first year, and after that between 30 to 60 years, right? So in infants within the first year, there are some classic lesions that you are going to see. Like I've mentioned before, when it comes to seborrheic dermatitis, you must watch out for the yellow scaling. That is what gives it out quickly. You look at the yellow scaling, you look out for the yellow scaling, and you look out for the distribution of the lesion. So in infants, it causes more like something that looks like a diaper rash, unlike atopic dermatitis. Atopic dermatitis in infants spares the diaper region. Why in seborrheic dermatitis, there's affectation of diaper region. So they have a severe reddish erythematous diaper rash with erosions and blisters, but they are covered by yellow scale. In fact, if that's the only thing you can remember, it will help you, trust me. Yellow, greasy scale. Yellow, grease scale. So the grease has to be there too. Yellow, greasy, scale. In the eroded areas and the blistered areas of the diaper. If you don't find the diaper, it can also be on the head. It can also be on the head. So you see the scaling, the yellow greasy scale and crusting on the scalp, and you call that the cradle cap. This is not the first time we are hearing this. The yellow greasy scale on the scalp, which you call the cradle cap, with the areas of erosions. That's what you call the cradle cap or dandruff. Very similar to dandruff. When you have that in adult people, you call that dandruff. The yellow greasy scale with erosions on the scalp. That's dandruff. That is seborrheic dermatitis. So those are the two common locations in the infant: the diaper area, the scalp. The diaper area, the scalp, and in the diaper area and the scalp, you are going to have erosions and blisters, both of them, but they are covered by the yellow greasy scale with erythematous background. So we can see the erythematous background. These are the areas of the erosion. These are the erosion areas covered by the greasy. You can see this grease-like yellowish scaling. So this is a cradle cap, seborrheic dermatitis. In adults or children, you see it at the central face. What do I mean? You see the yellow greasy scaling, you know, you see the erythematous plaque covered by the yellow greasy scale. So erythematous plaque covered by yellow greasy scale within the eyelids, like this woman. You see it within the nasolabial folds. So along this area, very common. You see it in the cheeks. Then you go to the back of the hair, the post-auricular areas. They are very, very abundant there. Those are the typical areas where you find seborrheic dermatitis. So by the time you see the question stem saying there's the yellow greasy lesions or plaques, distributed along the eyelid, the nasolabial folds, the cheeks, the back of the hairs, my friend, we already know that this is seborrheic dermatitis they are talking about. They can ask us, what's the implicating organism? Malassezia four that colonize area that is high in sebum, right? Areas with abundant sebaceous glands. So, having said that, we already know the implicating organism, so that we are going to tailor our treatment towards that. So that's why you use the antifungal agents, particularly as shampoos to wash out the head of the individual. If it's because it can also, before I forget, it can also occur in the scalp as dandruff too in adult people, in children and adults. So you have to apply antifungal agent. So to be sure I'm not missing out everything. Yeah. So it's very common in people with HIV/AIDS, psychotic disorders, and Parkinson's disease. We have to take home this point. HIV/AIDS, Parkinson's disease especially, and psychotic disorders, right? Some will also say stroke people. So people with CNS problems, stroke, Parkinson's disease, psychotic disorders, to people with HIV, they usually have a widespread seborrheic dermatitis. So it's usually very severe. You see multiple lesions everywhere, and it's widespread. So think about HIV, think about Parkinson, think about psychotic disorder, think about stroke for individuals with widespread severe seborrheic dermatitis. So this is a question for us. A 23-year-old woman is seen for an itchy, linear. So there's something already running through our mind. We have a pattern, linear angular rash on the right leg. You can see the limbs. She returned from a camping 4 days ago and denies using any new makeup, clothing, jewelry. This individual is already ruling out potential allergens. What features of this presentation favors contact dermatitis? So to me, what favors it? Number one, the pattern of the rash. It is linear rash. Number two, the area where it's affected. Right leg, which is typical for contact dermatitis. Usually see it in the limbs, the extremities. This person also went for camping. So most likely the person might have gotten exposed to the plant contain the urushiol, right? The urushiol plant, which includes the plant poison ivy, the poison oak, and poison sumac, right? So those are the things. And the examination findings for seborrheic dermatitis history is also sufficient. It's clinical. You you can confuse it with topical dermatitis, with atopic dermatitis, contact dermatitis, and psoriasis. But how do you treat? Right? So we give the antifungal shampoo if it is localized to the scalp only, right? So you just give the shampoos, the ketoconazole, the selenium sulfide, right? Selenium sulfide can help, treat the condition. The antifungal like ketoconazole or your zinc pyrithione. If we can remember zinc pyrithione, it's fine. Most of the time, your selenium sulfide and your ketoconazole is enough because we have so many things to learn, right? So for the scalp, but if it's after anything beyond the scalp, the face, commonly the face, you can apply your topical antifungal agent like your ketoconazole cream or topical corticosteroid for those areas. If it occurs in the scalp in babies like cradle cap, you can just do your routine bathing and application of emollient. It's going to cure it. Just bathe that area very well, apply the emollient. It's going to treat it. But if it's adult with dandruff, give your ketoconazole shampoo, your selenium sulfide, or your zinc pyrithione shampoo. Even in the face, apply your topical ketoconazole cream or your topical corticosteroid. You can see it's very easy. So, seborrheic dermatitis, for widespread cases, think about CNS problems, Parkinson's disease especially, stroke, HIV, HIV, psychotic disorders. Very important. For psoriasis. So psoriasis is another fantastic lesion that it's commonly tested, and it's part of the papillosquamous lesions, just like lichen planus. It is a T-cell mediated inflammatory dermatosis. You know, it is a T-cell mediated inflammatory dermatosis characterized by well demarcated erythematous plaques. So we have said papillosquamous. So majority of what you are going to be seeing are plaques. So they are going to be raised and they are going to be more than 1 cm. And they'll be well demarcated. You can outline their borders, well demarcated lesions, with whitish, silver-like scales, or they call them micaceous scales. So once you see that, these whitish, silver-like erythematous lesions, erythematous lesions with whitish, silver-like scaling, think about psoriasis. Think about psoriasis. Erythematous lesions that consist of plaques with white micaceous scaling, whitish, silver-like scaling. That is psoriasis they are trained at all. It's very easy to get. And one thing that is going to help us nail it totally is that you are going to be seeing it at the extensor surface of the body. Extensor surface of the body, unlike its twin brother, which is the lichen planus, that you are going to see in the flexural areas of the body. But for psoriasis, it is the extensor areas of the body. And what do I mean by the extensor areas? You are going to see it at the elbows and the knee. You can also see it at the back and the lumbosacral region. But it's very common, and also the scalp. But it's very common at the extensor part, which is the elbow, the extensor part of the body, like the elbows and the knee, right? The knee, the elbow, the back, the back, the back, lumbosacral area usually, and the scalp. Those are the common areas. Don't forget, they are well demarcated plaques, erythematous, with scale, with whitish scale covering, whitish or silvery scales covering. So I think we should use the silvery color more, not white. Yeah, so that we don't get confused. Silver, because the question stem might actually, tell us the scaling. Silver scales. Just pick your answer and you move. So, where do you see the lesions? We have said it. The lesions are classically found in the extensor surface, include the elbows, the knees, sometimes the hands, like I have here, the scalp and the lumbosacral regions, right? And there are some other core lesions that you see. Aside the skin, they can also affect the appendages of the skin, like nails. So we are going to see nail pitting, just like here. You see this pitting, this indentation of the nails. In fact, that might only be the lesion they are going to show sometimes. They'll show you the nails and you see the indentation in the nails. That's the nail pitting. Classic for psoriatic lesions. Classic for psoriatic lesions. Nail pitting, oil spots, and onycholysis. So lifting of the nail plate with even breaking up. So it is like oily deposit there, which is a oil spot, and sometimes you can notice like breaking of the nails, onycholysis, but the most important one here is a nail pitting. Very, very important stuff. Very, very important, right? The lesions can evolve with time. They might appear small and later they become bigger and they become confluent. You see, before they are like tiny, 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 tiny like this, and later they become big and they will start coalescing, together. So, and there's something we call the Koebner phenomenon, which is when you have evolution of new lesions from skin irritation or from trauma. So by the time you apply trauma to the skin, you notice that that area of trauma is going to grow new lesions. That is what we call the Koebner phenomenon. It's different from the Nikolsky sign, please. So I'm going to talk about Nikolsky sign later, in which you have like unroofing of the blisters by the time you apply your pressure. Well, here you're having new lesions appearing when you apply trauma. That is Koebner, and it's classic for one of the dermatosis that brings about this Koebner phenomenon is psoriasis, right? And you remember the labs, which are part of the trigger, the labs, lithium, the ACE inhibitors, the beta blockers, you know, they are very common drugs, the beta blockers, the ACE inhibitors, and the lithium. So they can cause eruption of the psoriasis. 30% of individuals develop psoriatic arthritis. Yeah, we cannot talk about psoriasis and not talk about psoriatic arthritis, which is arthritis affecting the small joints of the hands and the feet, right? So you notice that the lesions will affect the small joint of the hand and the feet, in which you are going to be seeing the individuals complaining of pain, swelling, particularly within the wrist, the metacarpophalangeal joint of the hands, the proximal and the distal interphalangeal joint of the hands. So they are going to be complaining of pain, swelling, and stiffness of that areas. And most of the time, they are going to have even some disfigurement of the joints. They can complain of, Schwann deformities, in which you just see that you have flexion of the distal interphalangeal joint. So it can happen in psoriatic arthritis. Of course, there's going to be negative rheumatoid factor because the history is going to be looking at somebody having rheumatoid arthritis, right? Although you don't expect affectation of the DIP joint, the distal interphalangeal joint in rheumatoid arthritis, but in psoriatic arthritis you have it. If you do your rheumatoid factor, it is going to be negative. And because it is part of the seronegative spondyloarthritis, the individuals can have sacroiliitis, in which they have like back pain, stiffness within that area. So don't forget that for psoriatic arthritis. 30% of the cases of psoriasis, have complicated psoriatic arthritis that affect the small joints of the hands and the feet. How do you make your diagnosis of psoriasis? How? You have to know everything about psoriasis. What are you going to find on your examination findings? We know what to see. We know what we are looking out for. Your well-defined erythematous papules with silver-like scaling or the Mercatus scales. There's something we call the Hospice sign. There are so many signs, but one of them is the Hospice sign, in which when you try to scrape off the scales, you are going to see pinch point bleeding due to exposure of the underlying dermis. So the vessels there will start bleeding. It's very classic for psoriasis, and that's what we call the Hospice sign. Pinpoint bleeding when you scrape off the scaling. You can perform a biopsy if you are uncertain of whatever you are seeing. And what you are going to see is that on histology, you are going to notice thickening of the epidermis. So the epidermis is going to be thickened, particularly the stratum corneum and the stratum spinosum. Those areas are going to be thickened, right? Hyperplasia of the stratum spinosum is what we call acanthosis. So acanthosis is going to happen in people with psoriasis. There's going to be thickening of the stratum spinosum. There's going to be thickening of the stratum corneum. There's going to be parakeratosis. And parakeratosis means retention of the nuclei of the keratinocytes in the stratum corneum. Normally, when they get to the stratum corneum, they are supposed to lose their nucleus. But it's going to be retained in people with psoriasis, and that is what we call parakeratosis. So you can see this in the question as the answer. As part of the options that you have made a diagnosis of psoriasis, fine. The next thing is what will be your finding on histology, right? So preservation of the nucleus in the stratum corneum, which you call parakeratosis. There's going to be thickened epidermis, the stratum corneum, the stratum spinosum. There's something you call along the rectal ridges. So this rectal ridges is just like protrusion or projection of the epidermis into the papillary dermis. So the projection of the epidermis into the papillary dermis is what we call the rectal ridges, and they become so elongated in individuals with psoriasis. And if you check the granular layer of the skin, it's going to be absent, like it's going to be reduced. So unlike what you have in lichen planus. So the granular layer of the epidermis is absent in individuals with psoriasis, while in lichen planus it is, thickened. There's elongation of the rectus regis. There's preservation of the nuclei in the stratum corneum, which is the parakeratosis. And lastly is your Monro microabscesses. which is neutrophilic infiltrate in the stratum corneum. In lichen planus, we have infiltrate within the dermo-epidermal junction. Those are the salient differences. But in psoriasis, you have neutrophilic infiltrate in the stratum corneum, and we call that the Monro microabscesses. Don't forget, the granular layer is absent. In lichen planus, the granular layer is thickened. In psoriasis, the stratum corneum and the stratum spinosum are thickened. There is retention of the nuclei of the stratum corneum, in psoriasis, which you call parakeratosis. There's neutrophilic infiltrate in the stratum corneum, which you call the Monro microabscesses in psoriasis. So when you have a rash involving the extensor surface, think psoriasis. When the rash is papulosquamous and it involves the flexor, think lichen planus. But if the rash is papule and vesicular, affecting the flexor, think atopic dermatitis. So how do you manage these individuals? Treatment depends on the extent of the disease. So if the areas affected are less than 5% of the body surface area, so that's a local disease. So you just give your topical steroid, your topical vitamin A, and your topical vitamin D derivative. That's where I remember it. So your vitamin D derivative that you have is what you call calciprotterine. While your vitamin A is the tazarotene or acitretin. So for psoriasis, just remember your vitamins and your steroids. So vitamin D, calcipotriene, vitamin A, tazarotene or acitretin. Then your topical steroid, acitretin, tazarotene, calcipotriene. For severe disease or any individual with psoriatic arthritis, once you are having psoriatic arthritis, it's already becoming severe, right? So you have to use your DMARDs to give your methotrexate or anti-tumor necrotic factor biologics, which includes etanercept, right? Infliximab, and your what? Adalimumab. So any of these, can take care of severe disease, more than 5% of body surface area affected, and also any evidence of psoriatic arthritis. You can use other agents too, like your ustekinumab. Most of the time, you won't be asked all these things, just academic stuff. So ustekinumab, which is anti-interleukin against 12 and 23, and secukinumab, which is anti-interleukin 17. They play a role in the inflammatory response to psoriasis. So anti-interleukin 17 is secukinumab, or anti-interleukin 12 and 23, which is a ustekinumab, right? Sometimes you might need to do a UV light therapy, particularly if they are unresponsive to your earlier mentioned treatment, like your steroids, your methotrexate. You can do UV light therapy, especially if there's extensive skin involvement. But you don't do UV light therapy if an individual is immunosuppressed because of the risk of developing skin cancer from UV light. We are going to talk about this later. So before starting any of your biologics, like the anti-tumor necrotic factor biologics and your methotrexate, you have to do some basic investigations, right? Which involves checking your complete blood count, because both of them they can cause suppression of bone marrow and anemia, neutropenia, and the likes. You have to do your comprehensive metabolic panel, assessing your electrolyte, urea, and creatinine, and the likes. Because these guys are going to be excreted by the kidneys, right? You have to ensure that your kidneys are working well. You might also need to do a hepatitis panel, and at the same time rule out a latent tuberculosis by doing your PPD test or your interferon gamma release assay. Both of this is necessary because you can have reactivation of latent hepatitis or tuberculosis infection by giving your methotrexate or your anti-tumor necrotic factor. So you must make sure there is no latent hepatitis infection or latent tuberculosis infection that can erupt by the time you commence this medication. So the sausage digit and the pencil in cup X-ray finding are suggestive of psoriatic arthritis. I almost missed that, and I have an X-ray that shows that. So dactylitis, which is more like inflammation of the digits. So you are going to see erosion of the bone, which is a pencil, and the overlying bone is a cup. So this one here is a cup. This is a pencil that's getting eroded. So pencil and cup deformity is one of those characteristic X-ray finding in individuals with psoriatic arthritis.